Okay, so where we left off in class was really what happens when there's light. So, as I said, when there's light, you have depolarization of the ganglion cells and they release glutamate on the SCN, which is a suprachiasmatic nucleus. Now, these are GABAergic. Now, not shown on this is actually their synapse to the paraventricular. Now, the paraventricular, which is not shown here, works by sending descending fibers to the spinal cord. Now, these descending fibers are excitatory. They release oxytocin. So before I go to what they actually do, so these are the ones that are sort of inhibited. So they won't release as much oxytocin as they would naturally do. And these descending fibers go and synapse on this component here known as the intermediolateral component of the spinal cord. And then we find our preganglionic cells being excited if oxytocin was there. So naturally, here's how they work. So oxytocin will excite these preganglionic cells, which are cholinergic. And once they release SCH in the superior cervical ganglion, they're going to allow for the postganglionic cells or neurons, which are adrenergic, to release norepinephrine. And the norepinephrine is going to then bind to the beta adrenergic receptors, and thus it will cause melatonin to be produced. But what we have here is you have glutamate coming through, and you have the suprachiasmatic nucleus being excited to release GABA. This will inhibit the paraventricular nucleus from releasing oxytocin, which is what is used to excite the preganglionic cells. So once that is inhibited, you find that there is no SCH that is released, and no SCH means you do not have any norepinephrine being released here by the pineal gland. And if there's no norepinephrine, then there's no binding to the beta adrenergic receptors, and thus you have no melatonin being produced. So this is what's going to happen during the day when there's light. But here is what happens when there is a reduction in light. So when there is a reduction in light, you have a reduction in glutamate. So reduction in glutamate means its release in the suprachiasmatic nucleus is reduced. That means there is no excitation of this red colored nerve, so to speak. So this GABAergic neuron will thus not release GABA onto the paraventricular nucleus. So reduction of GABA release on the PVN will result in increased oxytocin release onto the intermediolateral component of the spinal cord. And thus you have more SCH that is being released onto the superior cervical ganglion, and this will excite the postganglionic cells that will then release norepinephrine. The norepinephrine will act on the pineal gland by attaching to the beta adrenergic receptors, and thus you'll have melatonin that is released into the blood. Then this will lead to more sleep. So what we can observe during the day is that there's really a reduced or a decrease in melatonin levels within plasma until we get to the evenings around 20, where there's an increase. and about 02, that's where we have the peak, which is in the middle of the night, and then that goes on until just about 3 to about 4 o'clock, close to 5 o'clock. That's when you now see this decline, and then the day continues with these low levels below 10 nanograms per mil of melatonin. So again, this is just to emphasize that increased melatonin in the plasma will allow for sleep, whilst the opposite will allow for unawake state. So now I just want to talk about types of dreams. During your state of sleep, you have two types of dreaming that can take place. Non-REM, which is the first component, the 75%, you have dreams that are a little bit vague and images are more fleeting. You can't quite make realism out of them. But in REM sleep, these are very clear and the plots make sense, even though they're really unrealistic, but they do make sense. Why we dream, according to Freud, we dream because we are reflecting someone's unconscious wishes and urges. They're symbolistic, but from the biophysiological or biopsychological perspective, what we see is the neurons are randomly firing and the brain tries to make sense of it. That is why we have dreams. Very interesting to note is which parts are actually active or inactive during dreaming. I'll just go through this by Hobson. It says the gray components are the ones that remain inactive. So I'll start with the more active ones. So during sleep, you have this visual association cortex, as well as the limbic system and the cerebellum, very active. And this is because, well, you need to see this image construction that takes place, and there's also perception of movement whilst you are dreaming. There's also an emotion tied to our dreams, so we see that these areas are actually very much active. The stem and the thalamus are said to be active, giving us this rapid eye movement that takes place. Now, the inactive parts are the motor cortex. You see that the body is paralyzed, like we said earlier. And then working memory, the will and the control are also reduced. So you have this irrational behavior that happens when you're dreaming, almost as though you can't control it. But you can still feel it. That's the amygdala emotion component of it. Something that I would also want to point out is that the dream imagery may not be identifiable, but it's definitely there. You can see it, but it's not all the time that you make sense out of it. And the language and the words and the names, you can tell these are definitely there, though it's not all the time that you will remember them, depending on which part of your cycle you are dreaming. So lastly, just want to go through a few sleeping disorders. Some of them include insomnia. So in insomnia, you see that it's a state in which you cannot quite sleep. You're having difficulties in sleeping. And so there are a few things that have been noted to actually help in sleeping. So if you don't sleep within the first 5 minutes you get into bed, you get up, or you can change to go into another room or another bed, or you can use meditation and the things that we had talked about earlier to reduce the brain waves. Satisfying sexual experiences can also promote sleep, but this is observed more in men than in women. Narcolepsy is another type of disorder. Narcolepsy is chronic, and the brain is not able to regulate sleep or sleep-wake cycles normally. And so you just have this sudden loss of voluntary muscle movement, and then you fall asleep. There's this excessive sleepiness that is observed. So a regimen of forced naps at regular times of the day can help with this. When medication is required, stimulants are most commonly used in this type of pathology. So other components include restriction of breathing. You have restless leg syndrome that you will see in the clinic, and these are all part of pathologies that can occur. But when we talk about problems during sleep, such as nightmare and night terrors, what I want you to appreciate is the difference between these. So nightmares, these are, frightening dreams that usually you can wake up a person from REM sleep because they are really frightening. But the night terrors are more severe and you don't have memory of them. And usually these occur in the non-REM where there's more fleeting type of dreaming. Um, Sleepwalking. Uh, so this is just a sequence of very complex behaviors apart from walking itself. But what we observe is that it is initiated in the first third of the night during non-REM. So that is stage 3 and stage 4 of non-REM. And then you frequently progress without having full memory of what is going on. So you leave your bed and you walk about and do several other things that you might have no recollection of.